Hello, everyone. Thank you for being here again. I hope everyone is doing great since last week. I think we can wait just a few more minutes for people to join. I know that there are more people that signed in, so um, I can start by presenting myself again, and while we wait. So, if you are new here and you didn't see our last webinar, so my name is Anna. I'm a physiotherapist and I work for Sensing Future. I have a master degrees in human physiology, mainly in exercise physiology. I've worked as a physiotherapist in a rugby team and at a clinical level with neurology and orthopedic patients. Currently, I work with PhysioSensing, so my main well, how do I say, my job here is to try to develop our posturographic products in accordance to the newest and evidence, scientific evidence, and also to help our new clients to start using PhysioSensing. So I want to thank you for being here and for taking interest in our webinars. So let's just move on so I can explain you what is the goal of this second webinar. So our webinar today is the second part of a two-part webinar series. So for the people who could not attend and for the ones that want to review the first webinar, the video is already available on YouTube. So you can go to Sensing Future YouTube channel and you have on the playlist the list of webinars. So I know I don't recall the number of webinars that we already have there, but we have already some there. And the first one, so the webinar from last week is already available there if you want to review it or to watch it for the first time. So today we will explore the following topics. So we're going to see how to perform limits of stability protocol, the Romberg test, and the sit to stand protocol. How to interpret the results from those protocols, and how to create a customized rehabilitation session with PhysioSensing. Okay. Unfortunately, we will not have time at the end of our presentation for answering questions. So I will ask you to write down your questions and your notes. And if you want, you can scan the QR code and book a short meeting with me where we can discuss some of those questions or topics that you want to know more about. Okay, so this QR code is going to be present throughout the presentation, and you can just scan it. It's easy, and you schedule a short meeting with me. I will be happy to talk to you. Okay, so I think we can start. Let's move on. So for this webinar, we use our pressure plate. So the pressure plate is a baropodometric plate, so it measures COP displacement as well as the plantar pressure distribution. So meaning that we can have a complete posturographic analysis, as well have the weight distribution analysis between lower limbs and within the foot. That's why I chose this plate, because it's the solution that has more functionalities attached, and for this context, so the neurological context, we want to assess postural control throughout with the posturographic analysis, but it's also important to assess weight bearing distribution between feet, sorry, and within the foot, how the weight is being distributed. Okay, so let's start. So let's start by assessing our patient. Here's just a short clip to show you how the software works. So we are going to our protocols list. We are going to choose the protocols. This is just for you to see how is it. Okay. Yeah. But it's important to do a short recap from the last webinar. So if you were present last week, we talk about creating our fictional neurological patient to whom we want to assess balance control. And so we decided we want to assess proprioception, motor control, and also other function measurements. So we decided we want to perform the Romberg test, the limits of stability, and the sit to stand protocols, okay? And that's what we are going to do today. So let's start with limits of stability. So the limits of stability, just for summarizing, is a concept defined as the point at which the center of gravity approaches the limits of the base of support. So in other words, represents the maximum distance that an individual can displace its center of pressure without losing balance. So the typical range of movement in the fourth direction. So forward we have 8 degrees, around 8 degrees of range of motion. To the side, 8 degrees also to each side, and then backwards we only have 4 degrees of range of motion. So this area, so this balanced area, they represent our cone of stability, okay? And there's already a lot of studies that talk about the importance of this stable area and the association between changes on the limits of stability and an increase in fall risk in a lot of different contexts, okay? So how do we perform the protocol? So this protocol measures several movement characteristics in 8 different directions. So to the front, front right, back right, back left, and front left. So when the software changed, so the patient is the blue ball, and it has to start in the center. And when the target, the first target, so the first one will be the target at the front, changes color and the beep signal goes off, the patient has to move his body, center of pressure, as fast as possible towards that target. So the goal is to go as far as the patient can. So it's important to say that the goal is not to achieve the target. It's not like a pass or fail test. It's try your best to reach the target. And because the goal is to measure the distance that the patient can achieve. Okay, so after the patient moves his body to reach the target, he has to stay there for until the timer ends. So it's 8 seconds, and then he has to return to the center and repeat this for every target. So for the 8 targets. Okay. So this is the protocol of limits of stability. It's not an easy protocol to do in the first time. So what you can do is do one training protocol just to teach the movement, and because it's important to keep our body like a straight line, so the movement has to come from the ankles, and so it's important to train and to understand when the patient has to start moving, that he has to wait for the time to end, and he has to come back to the center, because if he's not in the center, then he will have to repeat that target again. So you can do training first, and then do a second protocol, an assessment, a real assessment protocol. Okay, this is just an advice. So let's move to the sit-to-stand protocol. So this protocol allows us to have an objective measurement of a function movement that is very important for daily life activities. So we do it every time. It's every day, multiple times a day. So it's a good function analysis, and that's why I decided to add him. So as you can see in the picture, the plate is placed in front of the chair, and the software will give a command to get up. So and the beep sign. So the patient has to get up as quickly as possible without using his arms, okay? And then it has to stand still for a while until the software says it can rest, okay? So this test has 3 trials, so he has to repeat the movement 3 times, okay? And then the Romberg test, which is very well known. So for our Romberg test, our software, we have 4 conditions, okay? Each condition takes 30 seconds to complete. The first condition and the second condition are performed with the patient standing on top of the plate, so the plate counts as a firm surface. The first condition, the patient stays with the eyes opened, so every sensory system is available for maintaining balance. The second condition, the patient has to close his eyes, so we are removing the visual inputs, and the patient has to rely on the somatosensory and the vestibular system. The third and the fourth condition, we had a foam. Okay, so the foam is placed on top of the plate, and the patient stays on top of the foam. Okay, so here we are reducing the proprioceptive input, so the patient has to rely more on the vestibular system and on the visual for the third condition. And on the fourth condition, the patient closes his eyes and is relying only on the vestibular system. And of course, it is normal to see an increased sway. It is normal because the patient is only relying in one sensory system. What is not normal is for the patient to fall or to lose balance, to take a step towards the swaying direction. So here the stance is the Romberg stance, so feet together, and it's very easy to perform and very fast. So let's move to the results. Okay, so starting with the limits of stability protocol. These are the graphics and the tables and the illustration that the software gives us. Okay, the first thing that we are going to look is the illustration of the center of pressure displacement in the 8 directions. And here we can see already that marked asymmetry between the right targets, the targets at the right, and the targets at the left. The targets at the left, the COP displacement is not good, but at the right, so there's almost no displacement. So this person is incapable of moving his or her body towards the target at the right. Okay, but we have objective parameters that we can analyze regarding the movement characteristics. So let's see what we have. So reaction time, very easy to understand. So I said that the protocol starts with the target changing colors, yes, and with a beep signal for the patient to start the movement. So the reaction time is the time between the color changing to red and the person starting the movement. So here we can see that the patient has a high reaction time, so it's above the normative values. There's a lot of reasons that this can happen. So we have to keep in mind that this is an evaluation tool. We still need to do our complete clinical evaluation and take into account the clinical history. I'm just going to give you some possible causes for these parameters to be altered and try to create a pattern here of results, if there's a pattern here. So one possible reason for having an increased reaction time is anxiety and fear of falling, and this is very frequent, mainly in elderly population. So if we see that the rest of the parameters are okay and the reaction time is high, we can think about these more psychological factors being the main cause for it. But it can also be a motor control impairment, so a person that needs more time to make anticipatory adjustments, so needs more time to prepare to initiate the movement. So also changes in cognitive processing, such as attention and focus. So some of these alterations are common in Parkinson's disease. Then we have movement velocity. So here, what we want is that the ideal is to have a high velocity. So this person can go from point A to point B quickly without any trouble. So when we see that the velocity is decreased, it suggests that something is not working correctly. So there's also a lot of reasons that this can happen. It can be due to changes in the somatosensory system, such as a reduction in proprioception that can be caused, for example, by alteration in the mechanoreceptors of the soles of the feet, or even a slower transmission of sensory inputs, and changes also in the central interpretation and organization of the sensory inputs. So meaning that a person is going to need more time to sense changes in position and movement and to adjust to these changes. So in matters of muscle activation. Okay. So we can see that our patient has increased reaction time and decreased movement velocity. Okay, so moving on to the other parameters. Now we have two parameters that, well, they measure the displacement. So it's the endpoint excursion and the maximum excursion. So the first one, the endpoint excursion, is the first point reached without adjusting the movement, without slowing down. So it was the first try. The maximum excursion is the maximum distance that the person achieved after adjusting something in the movement, like slowing down or adjusting the direction, but is the maximum point that the person reached. So we can see that our patient has decreased endpoint excursion and maximum excursion for all directions, but this is way more pronounced in the targets to the right again. So this again can be due to a lot of causes. For example, muscle strength. Okay, so mainly our posterior muscle chain, because it has to hold the body when leaning forward, but also the ankle mobility, and the presence of some rigidity. Okay, so there's there can be a lot of reasons for this. For example, if we think about balance strategies, a person that doesn't have the ankle strategy available, essentially, that person will have trouble completing the protocol. So there's a lot of reasons that this can be the presence of an injury in the lower limbs. So we always have to think about the rest of our clinical evaluation and patient history to understand and correlate everything. So then, just to finish the parameters from the limits of stability, and I think that this one is actually also very, very important, is the directional control. Okay, so imagine that you draw a line from the center position to the target that you want to reach. Okay, this direction control is a parameter that measures the percentage of movement that happen in the wanted direction. So on top of that line. So it's a very good parameter to assess motor control, and it can be due to central problems. Also, it can be due to changes in proprioception. A lot of possible causes for this. So in general, from a clinical perspective, so what we know is that individuals with better, higher, larger limits of stability can perform more complex activities, tasks without support, and are more capable of tolerating environmental challenge. So based on the results, the healthcare providers can design specific programs to expand and train these limits, because as I said, it is very important. It's a very important it's a very characteristic to that decreases the risk of falling in a lot of different contexts. And so it's very important to assess is a dynamic assessment, function assessment, and we can train this and understanding what's wrong and what is causing the limits of stability to be reduced. You can train that with your patient. Okay. And now let's move on to the results from the sit to stand protocol. Again, here are the graphics that the protocol, the software gives us. Okay. Let's start by looking to the statokinesiograms from each trial. Remember that I said that this protocol has 3 trials, so the person has to do the movement 3 times. What we say here is that there is an increased sway in the medial lateral plane, okay, and is more pronounced towards the left side. So we already saw that the patient had more movement towards the left side and almost no movement to the right. And here you can say that the patient is showing body sway on the medial lateral plane and towards the left side. So a pattern. Okay, let's first analyze the movement and try to understand how to read the graphic. So the movement starts after the software indicates the patient to get up. So movement starts with a flexion of the body, the trunk, and an increase in dorsiflexion, so we can transfer the center of mass from our buttock areas to our feet. Yes, and so this time between the start and the time between the start and the moment that our center of pressure arrives um, on top of our feet, it's called the weight transfer time. Okay, and if this time is increased, the movement is not going to be an efficient movement. Yes, and this happens a lot with in the elderly population, and it happened not with me, but with some of the patients that I have treated, that sometimes just the fear of moving from, a larger base of support and a stable base of support to a narrow base of support, which is the feet, and an unstable one. If this person is afraid of falling, and it so this sequence of movement will be affected, and the time that this person will take to complete the weight transfer will be larger, so it will be increased. Sorry. And so we have this parameter. Okay, the software measures this time. Then we go into the rising phase. Okay, so the extension phase, we have it here. And then we have the stabilization. So the person extends the body, and then he has to stabilize now over a narrow and a more unstable base of support. So we measure here the weight time transfer, okay, and again the rising phase and the stabilization phase, okay. So let's see the results we've got. First, I need to say that the blue line that you see on the graphic represents the weight that is being placed on the left leg, and the red one, the weight that is being placed on the right leg. Yes. So what we see is that during the rising phase, okay, this patient is almost bearing all the weight is being placed on the left leg. So there's a big difference between weight bearing during this phase. As you can see, the maximum differential is this green line, so it gives us the maximum weight difference being placed on each leg, and it's on the rising phase. So here we have again that this patient is not using his right side to do the movement. He's leaning towards the left and using the left side of the body to complete the movement. And we also have here the weight time transfer, so is increased way above the normative value. So this movement is not being effective. So I have here the patient is taking a long time to transfer the weight from the seated position to the feet, as I explained, and there's an asymmetry of weight being placed during the extension and stabilization phase. Yes, there's still a difference when the patient is stabilizing, so is always putting more weight on the left leg. Okay. Other parameters that this protocol also gives us is the rising index, which is the force that is exerted during the rising phase, so as a percentage of body weight. So it has enough strength to complete the movement, and it's actually okay, but it's all on the left side. Then we have the left and right symmetry that will give us an asymmetry, will inform us if there is any asymmetry of weight. And here we can see there is a big asymmetry and is in favor towards the left side. So the main alterations that with this patient and that we can assess with this protocol is that it shows to have a mediolateral sway and is towards the left side. It has a increased weight time transfer, and it shows that it has a great asymmetry on weight bearing, and is supporting more weights on the left leg during the movements and after. Okay, now the results from the Romberg test protocol. So here what we can see is the statokinesiograms from each condition and the tables with all the metrics from all the conditions. So let's just look onto the statokinesiograms very quickly. So this one is the first condition. So with a firm surface, so the patient is standing on top of the plate and he has his eyes open. Then the second, he closes his eyes. The third, we had a foam, but he stays with his eyes open. And the fourth, we had a foam and the patient closes his eyes. Okay, but let us analyze the parameters itself, because we can see differences. So what I usually advise for clinical use is to look into three parameters that are very easy to interpret, and they are well researched in different contexts, so they are validated, and they gives us a lot of information regarding postural control in different conditions. So it's the COP displacement, the ellipse area, and the mean velocity. However, I also have here the ellipse rotational angle that will give us the possibility to characterize the type of swaying. Okay, let's start by the COP displacement. So this measure is the total pass of the center of pressure during each one of the conditions. So we know that the higher this value is high, it means that the patient was unstable and was swaying more. So the center of pressure was traveling a lot on the base of support. So we want to have a small value of center of pressure displacement. Then we have the ellipse area. So this is the area that contains 95% of the center of pressure points. So again, if we have a large ellipse area, it means that we were having difficulties to being to being stable. So we were swaying a lot. So if we analyze the rotation of this ellipse, then we can also understand the predominant sway direction. So we can see if the patient was swaying more on the mediolateral plane or more in the anteroposterior plane, and more towards the left side or more towards the right side. And then the mean velocity here, the goal is to have the smaller values of mean velocity. So if we have an increased velocity, it means that we were swaying a lot, so and we were not able to control our body. So what we can see is that these values, they all increased significantly when we move from the first condition to the second. Okay, so when we remove the vision, there is a significant increase in the center of pressure displacement, the ellipse area, and the mean velocity, which means that the patient got way more unstable when we remove the vision. So probably this patient is relying a lot in the visual inputs as a compensation for probable proprioceptive deficit. It is the interpretation that we have. the third and the fourth condition, we are assessing more the vestibular and the visual system. Okay. We also know, we also can see that looking to the rotation angle, we can see that there's more swaying towards the left side. Okay, and this is the main information that we can obtain from the Romberg test. So summarizing, these are possible balance dimensions that can be changed, altered, sorry, and which parameter from which protocol we got that information. So for possible proprioceptive deficits, we have the limits of stability, the movement velocity, and the direction control parameters. And in the Romberg test, we have the COP displacement, the ellipse area, and also is not here, I forgot, the movement, the COP velocity. For reduced limits of stability that we know we measured that they are reduced, we look onto the endpoint excursion and the maximum excursion on the limits of stability. For the increased body sway in the medial lateral plane, we can look onto the statokinesiograph analysis from the sit to stand protocol and the ellipse rotational angle from the Romberg test. From the asymmetric body stance, weight, so during the movement and in a static position, there's an asymmetry on weight bearing. We can look onto the weight variation over time and the left-right asymmetry from the sit to stand protocol. And for a motor control deficit, a possible motor control deficit, we can look onto the movement velocity, directional control, this is like the main one, and the reaction time from the limits of stability. Okay, so this is our possible balance dimensions that can be altered, and so which parameter from each protocol that gave us that information. Okay, so now we finish our assessment. We know that this patient is having trouble transferring weight to the right and moving to the right side. He has a high body sway in the medial lateral plane, always towards the left side. So we are going, and also problems in motor control, movement quality. So now we're going to search and look onto our exercise list and try to create a rehabilitation session, choosing the best exercises and choosing the right parameters to fit the needs of our patient. Okay, so here is just again for you to see the software interface, the logic of the software. Okay, we have different categories of exercises. Okay. These ones with visual stimuli, here the protocols training and the load chart. So I'm going to show them to you. Okay. So again, we have 6 different categories of exercises. It's balance and stability, random points, figures and paths, exercises with visual stimuli. For people who rely a lot on the visual input, these exercises are good. And also they have optocinetic stimuli, protocols training, and load chart. So let's move. Let's start with, and it's actually the first category of exercises that we have on the software, which is balance and stability. So these exercises on this category are for static balance training. So, and this is the exercise that I chose in the medial lateral plane because we assessed that this patient had this asymmetry in weight bearing and was having trouble coming to the center, so distributing weight equally on both legs. So the goal with this exercise is to improve postural control while trying to distribute body weight equally on both feet to reach a stable position. Okay, and this is the visual biofeedback that the patient has. I have a video at the end of the presentation with this exercise. You will see it. Here's just a picture. So, but the main thing is learn and understand how to change and adequate the parameters to the exercise to the patient. So we have here the tolerance. So what does it mean? So the tolerance is the weight percentage margin allowed outside of the position, so the indicator remains green. Okay. So, for example, if we have 15% of tolerance, this means that the patient only has to have 85% of his body weight on the marked, the goal, the target, to validate the exercise, to keep it green, to be successful. Okay, so if we want to decrease difficulty, we will need to increase this tolerance. We will need to allow the patient to have less weight on the wanted position. Okay, and then of course we have the exercise time. These exercises, they look simple, but they are very tiring, and even for people that don't have any problems, but they rely on a really effort on postural control, muscle activation, focus. So it's good always to start with smaller time intervals and then to progress increasing the time. Okay. One of the most important parameters here for this patient is this one, the balance and the value. Okay. What it does is that since we know that this patient really has put a lot of weight on the left and is having a lot of difficulties to moving his body towards the right, what we can do in the beginning, we can shift the marked center of the exercise to the left, and we can choose the percentage that we want to change. For example, here is 10%, so we move 10% of the point to the left. So now this is the target area of the exercise, and we can progressively move the target towards the center. This can be a progression. So because if we do it in the center, in the real center, the patient will not be able to validate the dot and will be always red, and it's not good to motivate people. And so it's better to we shift a little bit so it gets more accurate to this person abilities, and then progressively we go towards the center. Then we can also change the stance position for this patient, comfortable normal stance position, and we can also add an unstable surface. So, and for this patient, we want him to be on a firm position. You know, we are all already thinking that he might have a proprioceptive deficit. If we had a foam, then we would be decreasing the proprioceptive input, and it would not work. So for now, we will keep it like this. Okay. Now, a second category that we have, which is figures and paths. So this is already training for dynamic balance. Okay. With this type of exercise, we can train weight transfer in different planes. elegant challenge in which a person must reach the dots to create a figure. So it's good for training and increasing limits of stability and overall motor control. Again, we have some parameters that we can change. We already talked about the tolerance, the exercise time. Now, one that is very important also is here, the limits. So we assess the limits of stability. We know that this person has really reduced limits of stability, and he barely reaches the 30% of the theoretical limits of stability. So to start, we can start by selecting around the maximum percentage that he got on the assessment protocol. And so with time we can increase the value here. So increasing here the limits of stability will mean that the patient will have to do a wider movement with the body. So the area of the square will increase. Then again, the training focus. Here, we can change this also. For example, if you want to just stimulate weight transfer and movement towards a specific site, you can select it. And now the patient, for example, if I selected here the right side, there only will appear targets on the right quadrants. I think for starts, and because he also has trouble moving on the left, as we saw, we can do a complete square, and then we can, because every time you do an exercise, there's a report, and we can compare the displacement on the right quadrants to the displacement on the left quadrants, and also continue the assessment while training, okay? Another suggestion is in the random points category. So the exercise Follow Me also is an exercise for training dynamic balance. So the Follow Me exercise implies reaching aleatory points with the center of pressure. So stimulating weight transfer in all directions and motor control. And it has the unpredictability effect of the location of the point. So the patient does not know where the point is going to appear. He appears and he has to go to the point with the center of pressure. So the parameters are similar to the ones that we saw. A different one here is also the time at the time at the point. Here we can choose a specific amount. Can choose a specific value for the time that the patient has to stay on top of the point to validate the point. So if you want to increase exercise difficulty, we increase the time at the point. If we want to decrease the exercise difficulty, we decrease the time at the point. Okay, so I put 2 seconds. So he has to remain on top of the point for 2 seconds to validate the point. Here you can also you can also choose to train only in specific quadrants. So if you say that you want more the training focus to be on the right, the points will appear more on the right quadrant. So this is what it means. Okay. Here we have the protocols training category, where we can train the protocol, the limits of stability. So this is the goal of the exercise, to improve limits of stability. Is the same. The patient has to move the center of pressure from the center to the targets in the 8 directions, the same as the protocol. But you can change here the parameters, so you can increase or decrease tolerance. You can choose the percentage of the limits of stability that you want to train. So if you want this, as we talked, this patient barely reached 30 something% of limits of stability, you can choose between 30 and 40. Maybe 40 is already too high for this patient, but you can change it and you can progressively increase the limits of stability. Again, we do not want to change the position, but if you have different patients, you can, of course, and to add a foam for this patient, it's not a good idea. Okay. Now, moving to a different category. So this category, load charts, the software has different charts that show life changings on the weight distribution and the weight transfer in the different planes. And so what you can do with this in this category is to create your own exercises while having this visual biofeedback regarding the weight distribution during the exercise. So we saw that the patient on the sit-to-stand protocol placed all the weight on the left leg during the movement of rising and on top. So what we can do is we can perform the exact same exercise, the sit to stand. We place a chair behind the plate, and we show this graphic of load distribution, and we ask the patient to perform the movement while trying to equalize the loads on the two bars. So it's a good visual feedback of the weight being placed during a movement. So it's a dynamic view of the weight being placed on the lower limbs. Okay. Here the parameters are very simple, same that we talk about. Another graphic that we have in loads load charts is the load distribution, the exercise global. Where we have the plantar pressure distribution, and it's live. So we can, for example, do an exercise such as heel raises and toe raises, and at the same time, we are seeing the amount of weight that is being placed in each foot. And if during the movement, the weight is being transferred to the anterior part of the foot and the posterior part of the foot, and if it is similar between feet. Okay, so this is the exercise. My colleague was performing the exercise for us. Okay, so this is a good exercise for balance and muscle strength of the plantar flexors and the dorsiflexors. So we do this a lot with patients with the fall risk. And here is the interface of the plantar pressure distribution during the movement. Let's see it again. So toe raises here, and now heel raises. Okay, so it's a good way to do this type of exercise with visual biofeedback. So then we have another exercise that we can do with a visual biofeedback. Now we used an exercise the same of the first exercise that I showed. The same exercise is the sagittal in the balance and stability category. So we can, for example, perform a squatting while giving this visual biofeedback. So we can ask the patient to squat, and this can be done with a chair or with the support of the wall or just a normal squatting, and try to maintain the center at the center position. So to maintain the bar green. Here again, for this patient, of course, we would shift the center to the left, and maybe we would add a chair here, just to serve as a support, not to sit, and would be something like this. So we want the bar to remain green. That means that the person is placing equal weight on both legs. So it's it has it's in a balanced position. So this is just for you to see what happens when the person leaves the position, the balanced position. Okay. And here is my colleague also just. Okay. Of course, you have to be careful using a wall. You have to trust the patient a lot. It's just to serve as a small support. You can do it with a chair. Okay, let's move. Okay, and to finish, just another suggestion. Suggestion. We have also in the load charts an exercise load transfer in the medial lateral plane. Here we want to stimulate movement, weight transfer to the right. And so we can ask the patient to try to reach something on the right and to reach a specific value of weight transfer here in the graph. So you can see how much the patient is, how much weight is the patient transferring from one side to the other side. These are just some examples. This exercise can be used for other contexts, so you just need to change the parameters and to have creativity to add more goals to the exercises. The visual feedback works really well for people that have this asymmetric weight stance, and so it's good to use while doing specific movements such as sit to stand. But the important thing is, and if for the people who already have PhysioSensing and are working with PhysioSensing, is try the exercises yourself and try to change the parameters and try to feel the difficulty changes while changing the parameters. So then you can start to create your own exercise sequences for specific patients, because you can do that on the software. You can create specific exercise sequences where everything is settled. The parameters, you have to choose every parameter, and you can save that sequence for a specific patient. So when that patient comes to you, you already have the rehabilitation session planned. Okay. So another important topic, and so every assessment protocol gives you a clinical report with those parameters that are assessed. And if you already have previous session, you will get a progress report comparing each parameter from each session. Even for exercises, you also get an exercise report where it's written all parameters that were chosen for that session, so you can compare different sessions and say, okay, so I did this exercise with 20% of tolerance. Now let's decrease this for 15, for example. And you can also have this this tool, which is important for a clinical, but it's also good to show to the patient so the patient can understand what's going on, what these parameters mean, that is getting better, that is now reaching to this point. He already has green bars, for example, so it's good also to get the patient involved. Okay. In addition to the exercises, we also have some games. Okay, so different games for the balance for the pressure plate. We have 7 games available. Each game has a set of exercises that allow load transfer in several planes and balance training. And they can be used for many therapeutic situations. So I have a video here, so yes. Let's see the videos. Okay, have 7. Okay. For example, we have here, I can show you too. We have the BART, which requires load weight transfer in the medial lateral plane to collect coins and move out, keep on, so to run away from the water. So it's only medial lateral plane, medial lateral weight transfer with this game, and also for moving through obstacles, it will ask the patient to stand on top of one leg. And you can change some parameters of the game. You can ask to have more movement towards the right side or towards the left side to increase the time in unilateral stance to the right or to the left. So you can choose some specifications. And here the 2D games involves the movement of the body in all directions to keep on the path and to try to avoid some obstacles and collect specific items of the game. So what I usually suggest is, it is good, for example, to warm up. Wait, sorry. So you can use the games in the beginning or maybe at the end of the session. So the patient can leave the session feeling good and like with a feeling enthusiastic about the rehabilitation process. But I think for the rehabilitation program, you should really invest time on the exercises, because we have more than 30 exercises. I just have shown you some, and you can create a lot of different sequences and change the parameters, and you can add visual stimuli. If you want to treat vestibular patients, you had the option to use the foam. There's a lot of things that you can do. Okay, that's right. So again, for additional info, you can visit our site or our blog. On our blog, we already have a few articles, small articles written about diverse topics. Maybe they can help if you have any specific questions or you want to learn a little bit more about something. Maybe the answer is there. It's just the articles are around like a 5-minute read, so they are very short and very easy to read. We also have an infographic and an ebook available now. So if you haven't received them or if you want to have them, you can email us, okay? And you will send them to you. I want to thank you again for being here and for taking interest in our webinars. I really hope that these two webinars were useful for you. If you already have PhysioSensing and you are still learning how to work with the software, I hope it helped. As I said, unfortunately, we don't have time for questions. So if you want, you can book a meeting with me by scanning the QR code again. And also you have here the site and the website and my email. And if you want to write me an email, or also I didn't say on this webinar, but I have for these last months, I have collected a lot of research. If you want to know something more about a specific context, I can send you some articles, okay? So thank you. And I really hope you like it. See you on the next one. Bye.